sense to us. Since it's caused by cerebrovascular disease, it would happen later in life as that buildup occurs. So it typically happens over age 65. Onset obviously can be extremely variable depending on the kind of lesions that they've developed in cerebrovascular tissue. Memory loss is prominent. One thing they don't usually have is they don't usually have that word finding difficulty like we have in Alzheimer's. So that gives us one way to differentiate between the two. And as far as assessment of risk factors, those are going to be the same things that we talk about every time that cause cardiovascular issues. Smoking, hypertension, diabetes, all those things that would cause us to have a heart attack are the same things that are going to affect their vessels in their brain. So how do we treat those? We treat them by focusing on minimizing those risk factors so that they do not continue to decline and develop greater lesions. The next type is Parkinson's disease dementia. This one has a slow progression. This one does occur more in men than women. There is some heredity to it, but most cases are idiopathic, meaning we don't know what caused them. So people can inherit it, but most cases I bet we don't. It's not necessarily even that. People are typically diagnosed in their 50s or 60s, although they can be younger. The 4 hallmark signs of this, rather than, I'm not worried about you memorizing, I know there's a list of symptoms on there, I'm not so worried about you memorizing that whole list of symptoms, but remember the hallmark characteristics for Parkinson's are bradykinesia, so Brady like bradycardia, B-R-A-D-Y, and then kinesia meaning movement, K-I-N-E-S-I-A, so slow movements. Bradykinesia, it's one word. I just broke it up. So Brady and then kinesia is all one word. So that's number 1. Number 2 is tremor. These people have tremors. Rigidity. And postural instability. So unstable posture, if that's easier to spell. $75 to 80% of those with Parkinson's will develop cognitive issues that go along with it. So it is very common. The dementia aspect is pretty common in clients with Parkinson's. Mostly memory changes, I think, are going to be the most prominent, but some of their other functions are affected. Typically, their language skills will remain intact, though. The next one is Lewy body dementia. This is the second most common to Alzheimer's. One of the things that's important about this population is that their symptoms are going to come and go. So their symptoms will wax and wane, so you need to educate clients' families. They may have good days followed by bad days. Some of the specific, it's on the slide, but some of the things I want you to remember, so you might highlight it, is that these clients may have repeated falls. It's towards the bottom of the list, like third from the bottom. Repeated falls, syncope, and unexplained loss of consciousness. They may also have depressions or delusions. It's a little bit difficult to diagnose because we also get Lewy bodies with Parkinson's, so it's not like you can just look for those and know for sure which one of the two they have. But one thing to remember is that some neuroleptics, which can be used for Parkinson's, will cause severe reactions in this patient population. So sometimes that's how it ends up getting diagnosed, is they put them on a medication for Parkinson's and they have a severe reaction to it, and then they realize that this is the kind that they have instead. So just kind of FYI for the future. Next one, and this one has probably become more prominent more recently, is traumatic brain injury dementia. This results from some sort of injury. This can be direct impact to the cranial cavity or direct impact to the head or rapid movement of the brain within the cranial cavity. So it can be something that hits the head, or you can also get it from a situation where your head moves so rapidly that the brain basically bangs against the inside of the skull hard enough to injure it without like a direct external force, but something that causes the head to move in that way. This one we see more of because it's very common in combat veterans. Another place that you may hear about it is professional football players is the other place that this has become. That's one of the things that's led to the new rules in football, like not having hits. I'm trying to think of the targeting penalties that you see now in football are a result of the fact that now we found out that people who played professional football for years and had all these small injuries to their head have actually like really early dementias resulting from it. It was interesting, and I don't know if I have it in this section. Oh, I do. Okay, then in terms of people with combat deployment, traumatic brain injury is actually more heavily associated with PTSD than how intense the battles they were actually in were. So people who could be in more intense battles, but if they didn't have the head injury component, they're less likely to have PTSD than clients who maybe were not in as severe battles, but had some kind of head injury during their deployment. Those clients commonly will also develop PTSD. So, and we'll see, you see a list of symptoms on there. This is really hard on families because you'll see that it affects a whole lot of different, tends to happen to people who are relatively young and has a lot of effects emotionally, behaviorally. So they may act different than what their family, so they come back from deployment and act differently than what they did when they were originally deployed and things like that. So it is an important one kind of for this time in our lives. An interesting symptom that they have that is not necessarily seen in the other ones is the anosmia, the inability to identify smells. That's down under physical disturbances. The next one is one we hear about occasionally in the news, but not one. I've never seen one. I don't know if the other instructors have ever seen a case of this. Prion disease dementia, which is kind of the human form of mad cow disease. So it basically generally results, well, it always results from a prion disease, oftentimes from people who've eaten meat that was contaminated with that disease. But it is also highly contagious, not usually through casual or airborne contact, but through blood and body fluids, and especially contact with brain tissues, cerebral spinal fluid, things that are involved in the nervous system. Those tissues can be extremely contagious. So it is important that if a client goes for an autopsy or a client passes away with this disorder, that you notify the funeral home because they're going to be exposed to those blood and body fluids that could be contagious to them. So it's important that if we suspect this is what happened with a client, that we notify people who could be exposed to those things. This one comes on very rapidly. 90% of clients die within a year. And the dementia typically occurs fairly early in the course. We don't really have a treatment for this one. We basically just treat the symptoms. The focus is on anticipatory grieving for the family and for the client while they're still that aware. Let's see if we have, how many more types do we have? I think we only have a couple. Yeah, we've got 3. Next one is HIV. I think Mrs. Martinez kind of addressed this a little bit in lecture. It only occurs, the major neurocognitive type only occurs in about 5% of late stage HIV clients. So not super common, but it can occur. About 25% will have a more mild version, mild cognitive symptoms from their HIV. There is no particular treatment except just treating the underlying cause, the HIV/AIDS viruses that are causing it. Kind of pre-prepare. It is something you want to educate your clients about, that they might start to notice some cognitive changes. And in fact, in young people who have cognitive changes and we can't find a source, HIV testing is one of the things that we might do to see if that might be an early stage change for them. This is the one that we get to that is somewhat reversible with conditions. Alcohol-induced dementia. It is actually a combination of 2 conditions that we'll talk about. It occurs with persistent excessive alcohol use, and the underlying cause is long-term deficiency of thiamine. So we're not talking about the effect that the client gets while they're actually intoxicated or while they're withdrawing, but this is like the long-term, even if they're not drinking right that moment, kind of effect on their brain. Both have origins in thiamine deficiency, and the reason that happens is because the excessive alcohol intake causes two things. One is that they don't eat as much because they're consuming so much alcohol often, so they have a nutritional issue. They also have a decreased ability to absorb the nutrients that they do take in. The first one is Wernicke encephalopathy. It's an acute medical emergency. Your symptoms are listed there. Ataxia is impaired coordination. You're also going to have some abnormal eye movements. Because of reduced absorption, your most effective treatments are to replace their thiamine by IM or IV means. Korsakoff syndrome is the longer-term version of that. So it's chronic rather than a medical emergency. Can also be called Korsakoff psychosis because the clients have that antegrade amnesia, so they're not making new memories of what's going on during those periods of time. And so sometimes they'll make up stories, which is where the confabulation comes from, to fill in the gaps in their memory. And so it seems like they're making up things that aren't real then. So it can seem like a psychosis when really it's probably just been filling those memory gaps. You've got the symptoms there. If a client can be caught early and will stop drinking, thiamine replacement will help and actually decrease that they can go back and regain some of their function, but only if it's caught early and they're willing to stop drinking. If they go back to drinking, it's going to continue. And early identification is important because the longer it goes on and the more cognitive function they lose, the less able they are to stop drinking, basically. Like the less able they are to use their resources and stop drinking, the more decline they have. So. Last one, I think, is Huntington's. It's another source. This one is highly inheritable. You've probably heard of this one. It is a dominant gene. So basically, if only one parent is a carrier, the child has a 50% chance of developing the disorder. The disorder does not skip generations, but most individuals have already had kids before they realize that they have it because it develops a little bit later. Diagnosis usually occurs in 30s or 40s. It may be as much as 15 years from the first time they have early indicators until they start to lose motor function. And then dementia typically follows behind the motor changes. Eventually the clients are unable to walk or feed themselves, like we talked about with Alzheimer's. It's a high burden on caregivers and families, especially when you consider the hereditary aspect of it too. So it takes a toll on them in multiple ways. There is genetic testing for this disorder, but you need to ensure that those results are kept confidential and that the client gets genetic counseling to go along with those results and therapeutic counseling to deal with the results of that genetic testing. Okay, let's take a break and we'll move into the nursing process. It's 1:23, so we'll do 10 minutes and come back at 1:33.